Okay, so
Yes.
I want us to look at, we're running late, but so far you're only 17. I don't know why. Leishmaniasis. So we had said that leishmaniasis is one of the hemoflagellates. It's a hemoflagellate. And there are about 20 different species in the genus of Leishmania. So all species are actually obligate intracellular parasites. They're obligate intracellular parasites. Let me see what is in my head is in this part. Apparently not. So just know that they're obligate intracellular parasites where they actually have two hosts. We have two hosts. We have the insect vector host, which is the sandfly, and then we have the vertebrate host, which can be man. Okay, so just know that it's an obligate intracellular parasite with two hosts. And those hosts, you'll be able to name them. You will say that the hosts are the insect vector host, and then we also have the mammal host, which can be man. Okay. So here we have the small mammals and the canines serve as reservoirs for these pathogens, which are then transmitted to humans by this sandfly. So the sandfly is what we're calling the insect vector host. Scientific name is Phlebotomus argentipus. Phlebotomus argentipus. So I think you can remember this from your microbiology. So then here, the next slide, we have the life cycle of the host, and we have this sandfly. This sandfly is what we're calling Phlebotomus argentipus. Okay, and it is actually the intermediate host. It is the intermediate host of the sandfly. So it takes in the blood meal. It takes in a blood meal, and then when it takes in a blood meal, just like a mosquito, it will transmit the promastigote into the human skin. So promastigotes are actually phagocytosed by the macrophages or other cells in the human body, and then they transform into mastigotes. Then the mastigotes can divide in various tissues in the body, and then when they mature, again another sandfly can come and take another blood meal. Yeah? When it ingests a blood meal, it's able to pick this parasite, and then once it goes into the parasite, it is ingested, and then the mastigote then transforms into a promastigote in the gut of the insect. Then it divides, and then again the sandfly can take another blood meal and inject the promastigote. So we actually have several stages of this parasite. Remember the promastigote. We have the amastigote, the epimastigote, and the tripomastigote. But the one that is actually taken in by the insect, the sandfly, is what we're calling the promastigote. And I forgot to emphasize that man is actually the definitive host. It is the definitive host. And that's why we're saying it is a definitive host. You'll check from last time's notes, because that is where we have reproduction occurring. So man can be the definite host or even another mammal, but here we're concerned with man. And in man, we have the amastigote. The amastigote is the form that this parasite is found in man, a mastigote. And it is a promastigote. Well, it is in the insect. So there are various types of leishmaniasis. We have the cutaneous, the mucocutaneous, I think we mentioned last week. We have the diffused, then we have the visceral forms. So depending on the type of leishmania, it will transmit a specific type of disease. Now, cutaneous forms, these ones are usually self-limiting. So we say they may not require any treatment, but they can leave disfiguring scars. The mucocutaneous, and it's caused by the species like Leishmania major, Leishmania tropica, Leishmania ethiopica, Leishmania mexicana. There are many that cause, remember I said there are many species, about 20 species. The mucocutaneous form, we said this time, we said it involves the mucocutaneous junction. And it is caused by species such as Leishmania brasiliensis. Yeah, brasiliensis. And then we have the visceral leishmaniasis, and this one is caused by Leishmania donovani. And this one affects the organs, hence the name visceral. Yeah, or Kala-Azar disease. So this is like the cutaneous form of leishmania, cutaneous leishmania. This is cutaneous leishmania. So it has disfiguring. It causes disfiguring scars. This one is mucocutaneous. Why? It involves a mucocutaneous junction. You can see this is the outer part of the skin together with the mucocutaneous layer. So the mucous layer and the cutaneous layer, it is a mucocutaneous junction. This one is diffused or disseminated cutaneous leishmaniasis, and this patient was actually a HIV patient. So this one is diffused or disseminated. This one is visceral, like the name suggests. The organs are involved. You can see the internal organs there have been highlighted, the liver, the spleen inside, and this person has got hepatosplenomegaly. This child has got hepatosplenomegaly. Now we want us to look at the type of medication that can be used for this condition. So first of all, the classic therapy for all leishmania is actually pentavalent antimony. So all of them, you can use pentavalent antimony, but there's been some increasing resistance. Okay, we have then liposomal amphotericin B, which we've covered before. Liposomal amphotericin B. We have miltefosine. Which we'll mention one or two things. We have got paromomycin, we've covered it before, and pentamidine. Okay, and then we have that's paromomycin and again gentamicin, another aminoglycoside. So these are some of the treatments that have been used for leishmaniasis. So we want to look at sodium stibogluconate. It is IV, an IV drug which is given. So this organic pentavalent antimonial compound is used to treat the early non-inflamed lesions. Let me see if that's what the notes are saying. So just say that this drug, pentavalent antimonials that include this sodium stibogluconate, if you go to the textbook and look for this book. This book I was using, I think at that time was, Goodman and Gilman. The figure is there. We also have meglumine antimoniate. So these are what we're calling antimonial compounds. Yeah, the antimonial compounds, and specifically pentavalent antimonial compounds. Sodium stipogluconate is one of them. We're saying the sodium stipogluconate is used to treat early non-inflamed lesions. This meglumine antimoniate is used also as a pentavalent antimonial, and it is these drugs, this class of drugs, the pentavalent antimonials, they are thought to be prodrugs. They're thought to be prodrugs that are converted to a toxic stibogluconate species, and that is what kills the amastigotes. It kills the amastigotes. Remember, we have said that the amastigote form is found in the human or the vertebrate or the mammal. So this is a prodrug. This class of drugs, we're saying they're prodrugs. They are then converted to toxic stibogluconate species that then kill the mastigotes. And these mastigotes, remember we said, are in the macrophages of the human or in the mammal. So this reaction, conversion to a prodrug, occurs in the mastigotes. Okay, it occurs in the mastigotes. Let's see how far this moves. It doesn't, but let me just tell you that the reaction that occurs in the mastigotes is under the control of an enzyme known as a reductase enzyme. It converts the inactive drug to the active drug. Okay, it's actually a prodrug. Okay, although they say the mechanism of action is unknown of these antimonials, the proposed mechanism is that the drug is converted to an active species by a reductase enzyme, and this is what causes the death of the amastigote in the macrophages. Now, these drugs, the pentavalent antimonials, they're usually actually used together with amphotericin B or miltefosine. Why? Because of resistance. So the efficacy here, that's what the slide is saying, the efficacy against different species may vary and is both based on local drug-resistant patterns. Cure rates are good, but there's resistance. Therefore, you will combine them, or they're usually combined with amphotericin B or miltefosine. When it comes to adverse effects, initially there are few adverse effects, but over the course of therapy, the stibogluconate can cause GIT symptoms, it can cause CNS symptoms like headaches, fatigue, and of course there's pain at the intramuscular injection sites. Okay, that can also cause abscesses. We have ECG changes that can occur in the T wave and the QT stage, this QT prolongation. The changes are reversible, but can lead to arrhythmias. So during the administration of the drug, ECG should be monitored. ECG should be monitored. So this is the structure of sodium stibogluconate, pentostem. Pentostem is the brand name, and as you can see there, it has got this stibogluconate species that will be converted to the active form by a reductase enzyme. We have the other drug we've mentioned is miltefosine. Now, miltefosine is actually an oral drug. The mode of action is thought to be unknown. Now, we've said you can combine it with sodium stibogluconate. The proposed mode of action is that it can alter lipid cell. It can alter the lipid metabolism or cell signaling in the parasite. Yeah, so these slides say that. So, active drug. So just say there's a proposed, or the hypothesis, proposed mode of action is to alter lipid metabolism. And cell signaling. The parasite. There's a third proposed mechanism of action. You can have a look at it. I can't remember it. So in the parasite, in the Leishmania parasite. So just have a look at what is proposed. Then it's an oral drug we mentioned, 28 days regimen. And we've said that you see it is usually combined with amphotericin B because of resistance. And then here, when it says the 28 28-day course of miltefosine was effective in New World cutaneous leishmaniasis. I don't know if I mentioned last week, but we have divided our leishmaniasis into cutaneous, into visceral, and into subcutaneous forms of leishmaniasis. But we can also, we had also said, or I think I said, or maybe not, but we can also say there is New World and Old World leishmaniasis. New World leishmaniasis is, of course, they say it's the Americans, the American forms of leishmaniasis. So here, when it says this book was a textbook, I think it's an American book, 28-day course of miltefosine to treat New World cutaneous leishmaniasis. We have the Old World leishmaniasis. So Old World is now the other countries. If you can put Africa in the Old World classification. So the side effects include diarrhea and vomiting in about 30% of cases. About maybe more, maybe 50 and above % of cases, but it's short-lived. We have elevation of liver enzymes, nephrotoxicity. Of course, the drug is avoided in children. And then there's rapid resistance developing. Hence, we combine it together with amphotericin B or sodium stibogluconate. Here's the oral capsule of miltefosine, and that is the structure of miltefosine. Okay, now we mentioned that maybe this slide don't have, but we also use amphotericin B. Okay, let's just add a slide here. So that then just put amphotericin B. The question is, we were using amphotericin B for fungal infections, and now we're using it for leishmaniasis or leishmania infections. And why are we using it together? Why are we using it for these two different drugs? So the thinking is that leishmania, so we'll say leishmania has a similar sterile composition. Has similar sterile composition to fungus, to fungi. So, and remember we said that in fungus, the drug binds to sterols, and then it can create pores, and the pores can cause cell leakages and therefore cell death. So the drug binds to sterols, and the sterols in the fungus were different than the ones in the human beings. So also the sterols in the Leishmania are different to the ones in the human being. Okay? So why is amphotericin B used for both uh, fungal infections and Leishmania infections? Because of similar sterile composition in those parasites, both the fungus and the Leishmania. Okay, I think you've covered amphotericin B before in terms of side effects, uh, etc. We've covered it before. Now, this Kalazar, what is this Kalazar? This Kalazar, we have said, is actually the visceral disease. Visceral disease. It is also known as what is it called? Black fever. Black fever. Okay. So um, the in endemic areas, yeah, where we have this zoonotic transmission, usually to control it, you have to destroy the mammal that is carrying the promastigote, usually stray dogs. In areas where there is anthropootic transmission, early diagnosis and treatment of human infection can reduce the reservoir and control the disease, because now the sandfly cannot then take a blood meal. Okay, the sandfly cannot take a blood meal. We had talked about, I showed you pictures last time, but maybe it's this class of the post-Kalazar dermal leishmaniasis. So this is, it develops 1 to 2 years after the patient has been treated and they have recovered. Yeah. So after treatment, the parasite can become dominant and it can become active. And then it involves the skin. It involves the skin. Yeah. So here it says restrict to the skin. Yeah. It is rare but varies. So some people can recover spontaneously, and others, of course, they carry the disease. So this is post-Kalazar dermal leishmaniasis. Post-Kalazar dermal leishmaniasis. So it then presents as a cutaneous infection that looks a bit like leprosy. So this is dermal leishmaniasis. So I think you will go and look at proposed mechanism of action of the drugs used in treatment of leishmaniasis. We have covered it. We have said we have the pentavalent antimonial compounds. Then we have said we have miltefosine. Then because of drug resistance, we can combine these drugs with amphotericin B. Amphotericin B. So do we have any questions? If you have no questions, we can move to the next hemoflagellate, which is the trypanosomes. Are you able to see my slides?
No.
Are you able to see them now?
Yes.
Okay, so this is the next hemoflagellate that we are covering. Just to remind you, the first one was Leishmaniasis, but we had other flagellates last week. Once we talked about the genital oral flagellates, Giardia and Trichomonas. So if you divide them, and why? They have flagell. They have the flagellate organism. So let's see what this notes is saying. So we have the African trypanosomiasis, or sleeping sickness caused by Trypanosoma brucei species. It's a subspecies, and it's transmitted by tsetse flies. It causes serious human disease. About 500,000 Africans carry this infection. So let me see what slide is very uninformative. So let me just tell you that this Trypanosoma brucei, just add it there. Let me see if it's in the other slides before I add it. No. Let me just give you a bit more information on this slide. We have from your microbiology, we have trypanosome brucei, and under this trypanosome brucei, we have the subspecies. That is why we're saying African trypanosomiasis is caused by Trypanosoma brucei subspecies. So this Trypanosome brucei has subspecies. These subspecies are brucei. Then we have gabiensis. How will I put it now? Brucei. Then we have Trypanosome brucei. So please. Then I can paste again and I say Trypanosome brucei rhodiensis. Those are the subspecies we mean. So brucei gabiensis, gabiensis. That's the spelling. Then we have Trypanosome brucei rhodiensis. Those are the subspecies. This notes should be referring to. And of course, when you write like this, you will put them under italics. So those are subspecies. Let me also point out that we can have another type of trypanosome that is really covered in the textbook, and trypanosome, it is the American type, cruzi. And this one is what causes, just say it causes American or Chagas disease. Chagas disease. Okay, just to remind you. So this American version of it, there's something called as the Rudvid bug, yeah? So it is in a textbook, so just have a look at it. So we know it is transmitted by something. It used to be called the Rudulit bug. There's a scientific name for it. You'll have a look at it. And actually, the human is the definitive host. The human is a definitive host. And then in this Chagas disease, the infective form is actually in the species of, not in the species, in the feces, in the stool of this parasite. It is in the stool of this parasite. Okay. Now, that is the American form. So for us, we talk about this Trypanosoma brucei subspecies. That's why we're talking about it as a subspecies, because we have these three subspecies. So this one in Africa, or this one, that infects us, there's a tsetsefly. This one, we talk about this insect, the tsetsefly. The tsetsefly, that is important. In this other one, we have the Rudwig bug. And this Rudwig bug, we're saying the parasite is actually in the stool, in the feces of this insect. It's in the stool. But the tsetsefly, this one, it's the one that is involved in our African disease. Okay, and of course, since there's traveling, you might even see patients who have this Rudwig bug, or even a Kenyan or an African can go to America and actually suffer from this trypanosome transmitted by the tsetsefly. So the T. brucei, only the trimastigate forms are present. Okay, in the T. brucei, only the trimastigate are present. Those are just small notes, right? Don't write, it's okay. In the gabiensis, it's from your microbiology. In the gabiensis and the rhodiensis, you need two hosts. So in the brucei, you only have the tropomastigate forms present in the brucei. Only the tropomastigate forms are present. But in gabiensis and rhodiensis, we need two hosts to complete the cycle. You need the human host, and then we need the intermediate host, which is the tsetsefly. Okay, and remember this tsetsefly, we used to say it is the what? It is the Glossina species, or the Glossina genus. I think it's a genus. Glossina genus. Okay, the Glossina genus species. Okay, so just remember that. So for the gabiensis and the brucei, we're talking about two hosts: definitive host, which is human, and then we have the intermediate host, which is the tsetsefly, or the Glossina host, Glossina species. If you look in the textbook. Now, how is it transmitted to the human being? So again, the tsetsefly takes a blood meal. The tsetsefly will take a blood meal and transmit what? It transmits what we call the metacyclic tripomastigotes. It transmits the tripomastigotes during a blood meal. The metacyclic tripomastigotes that go into the skin. So there are two life cycles here. We have now divided them into the one that is for the intermediate host, which is our insect, tsetsefly, and then the one that is our human side. We look at first this one. So once it injects this metacyclic trypanoma, the metacyclic tripomastigotes into the skin, they usually change into long forms, short forms, actually long forms and intermediate forms, and then into short forms. Yeah? And then they go into the blood. And once they go into the blood, another tsetsefly can take a bite from the human being, and then it then goes into the insect and then changes again into the long forms. Yeah, and these long forms again are what infect the human. Yeah, So the short form is the infective form of the metacyclic trypomastigotes. Okay, but they are picked in different stages. They're picked in different stages. So that's why we are saying that we have the bloodstream trypomastigotes that can transform into procyclic trypomastigotes in the gut, and this can translate again, change into the procyclic trypomastigotes and then to the epimastigotes. But the insect injects into the human the metacyclic trypomastigotes. So what happens when they're in the human? Once injected into the bloodstream, they are carried to other areas of the body. They can multiply by binary fusion for example, in the blood, in the lymph. The trypomastigotes go into the blood. Again, they are picked. Okay, they are picked. So we have two hosts: human host, definitive host. Right? Definitive host. And then we have intermediate host, sessile. And here you will see, like, unlike the mosquito, both the male and the female of the tessefly can cause this condition. It's not only, like in the mosquito, we'll see it is only the female Anopheles mosquito. Okay. Now, the T. gabiensis causes, let's see if we've written, there's a slide for that. So let's first look at this slide. This is a bite by the sessile. And the sessile here can then transmit the metacyclic trypomastigotes into the skin. That is a bite. This one just gives us the symptoms. We have the short-term symptoms. You can have the ulcer, like the skin ulcer, myalgia, arthralgia, fevers, lymph node enlargement. Then we can have the long-term symptoms: lethargy, tremor, meningoencephalitis, mental retardation, general deterioration. Then we have the final stages of the disease: convulsions, hemiplegia, comatose stage, and then death. That's how the patient will present. So this slide just says that the parasite is entirely extracellular, and early infection is characterized by the presence of the replicating parasites. That's what I was telling you. You have them, it just keeps replicating, forming long forms, intermediate forms, and short forms. Yeah. Manifestation of early disease, we've already said we have these fevers, then later on progresses to other signs and symptoms. Stage 2 is where we have the CNS involvement, and then we have death. So there are two types of the African disease. Remember, we said that the trypanosome, the trypanosome brucei rhodiensis, the subspecies rhodiensis. And just to mention, this one, the T. brucei rhodiensis, is what causes the East African. It causes, just remember, it causes East African trichomoniasis, sleeping sickness, trypanosomiasis. And then this West African type is caused by gabiensis. So to remember, Gambia is in West Africa. So the West African type is in the Gambian area. And this one is what causes the West African type of disease. So West African trypanosomiasis or sleeping sickness. Now let me point out that the West African type has got long-term progression. Let's see, these notes are saying that. The T. gabiensis causes illness characterized by later CNS involvement and a prolonged course that progresses to the classic symptoms. So this one, it just means it's long-term progression, later CNS involvement. Okay. But the East African type, this one, has got rapid or early CNS involvement and cardiac failure. Okay, that's the difference. Our East African type here is more has a faster progression, CNS involvement, cardiac involvement. The West African type, long-term progression. Later, CNS involvement. Symptoms, we said, it depends on where the site was, where the site was. Okay? Um, and how do you differentiate the T. brucei, the T. brucei rhodiensis from the T. brucei gabiniensis? It can be diagnosed by blood, yeah? Species infection can use blood, you can use CSF fluid. And of course, the CNS symptoms are there. We will look at them in the previous slide. Have a look at them. So now, what are the treatments for this condition? What are the treatments for this trypanosome hemoflagellate? We have pentamidine for T. brucei gabiensis. We have suramine for T. brucei rhodiensis. Okay? So these agents are not effective against late-stage diseases, and standard treatment for the CNS phase is a drug we call melarsoprol. So in short, we are saying we can use pentamidine, we can use suramine, only when there's no CNS involvement. Only when there's no CNS involvement. Suramine and pentamidine. Why? Because suramine and pentamidine do not cross the blood-brain barrier. They don't cross the blood-brain barrier. That is why once we have CNS involvement, you need a drug that can cross the blood-brain barrier. So in late-stage disease, where you have got CNS involvement, we use a drug known as melarsoprol for CNS disease. And just to tell you that it's a drug that can cause itself fatal reactive encephalopathy in about 5% of patients treated with it. Okay. Then we have another drug known as eflornithine. Now, eflornithine is an orphan drug. Eflornithine is the only alternative for the treatment of late-stage disease, yes, and it has marked efficacy against early and late-stage human T. brucei gabiensis infection. So you can use it for early and late-stage disease in T. gabiensis. T. gabiensis, that's a West African type. But not for T. rhodiensis, the East African type. It is highly expensive, yeah, difficult to administer. It is ineffective as a monotherapy in the treatment of brucei rhodiensis, which is our East African type. Now let me ask you, have we ever heard of eflornithine before? Are we together? I've just been talking to myself. Have we ever heard of eflornithine before?
No.
No. Have we? What about in what did we cover? In dermatology, in the pharmacology of dermatology, where we talked also about hair. We talked about excessive growth of hair in the female. It's last semester. Is it? Maybe this class is last semester. We covered in dermatology of the skin, the hair, and the nails. We talk about eflornithine cream. Anyone can remember?
Yes, we did.
Yes, we did. So you find this drug as a cream for what? Yes, June. For what? Did we cover it?
For hirsutism.
Yes, for hirsutism in females. Okay? In females. So it is the same drug, but now here it is being used for sleeping sickness or late stage, early stage T. brucei gabiensis. Now, in the other unit, we covered it as a cream. You'll even find it being sold across the counter in a different form. Okay. Now, let's see in these slides. Cover the drugs. Yeah, I think we can start with pentamidine, which we have said is used in early disease where there's no CNS involvement because it does not cross the blood-brain barrier. Does not cross the blood-brain barrier. Pentamidine. Okay, pentamidine. Have you ever covered pentamidine before? Not with me, maybe, but I don't know if you can remember. It can be used for pneumocytic pneumonia when it is an inhalation. It can be used for pneumocytic pneumonia. Yeah. So this kind of drug is broad spectrum from some protozoa. For example, these trypanosomes. It can also be used for some fungi. Yeah. Pneumocystis pneumonia. Pneumocystis jirovecii or Pneumocystis carinii. It's the same thing but renamed. Pneumocystis jirovecii or carinii. It was renamed. It causes pneumocystis pneumonia. Let us check if the notes are saying that. Sorry, some notes are from my head. But this pentamidine has been used since 1940, drug of choice for early hemolytic disease caused by Trypanosome brucei gabiensis. Gabiensis, when this is Gambia, this no Gambia is in the West, yeah? So, the West African type of sleeping sickness. The drug is inferior to suramine for treatment of early East African sleeping sickness. So, for early East African sleeping sickness, early meaning it has no CNS involvement, suramine is our drug of choice. Now, pentamidine should not be used to treat late stage trypanosomes with CNS involvement. I've given you the reason why. It does not cross the blood-brain barrier. It is an aromatic diamidine formulated as an isothiionate salt. Here you can see it is pentamidine isothiionate for injection. Yeah. So where is that? We're saying it is formulated as an isothiionate salt. The drug is only administered parenterally. It leaves the circulation rapidly with an initial half-life of about 6 hours. Is bound avidly to tissue. Accumulates and is eliminated very slowly with a terminal half-life of about 2 weeks. Yeah, about 2 weeks. Only trace amounts of pentamidine appear in the CNS system, so it is not effective for CNS disease. Pentamidine can also be inhaled as a nebulized powder for prevention of pneumocytosis, yeah, or pneumocystis pneumonia, yeah. And then I wanted to write. That's I wanted to remind you where else you have seen this drug. It is inhaled for prevention of pneumocytosis. Yeah. So you will just know, just remember it that what do you remember? That pneumocystis jirovecii. Later on, it was actually renamed to the same pneumocystis. It was renamed to pneumocystis carinii. The same one, depending same one. Pneumocystis carinii cause, this is what they causes pneumocystis pneumonia. Causes pneumocystis pneumonia. So this one is a note. So by the way, for you to remember, where else have you seen this disease? I mean, this drug? It's for, and here when it's being used for this pneumocystosis, it is actually given as an inhalation. Yeah, actually given as an inhalation. Mode of action is unknown. Yeah, mode of action is unknown. But now in an academic era or some institution that is academic, so you will say that the proposed mode of action. It's thought to, you can check the book, it actually can concentrate in the cells and cause and have or form highly reactive molecules, yeah, that can affect the parasite. So it concentrates in the cells, and then it can exert its effect by interacting with negatively charged intracellular targets. That is our hypothesis. Yeah? And this can cause inhibition of DNA protein synthesis and enzymes in the parasite. So mechanism of action is unknown. Then you say it is thought. You say it is hypothesized. It's hypothesized, proposed. It can concentrate. Proposed concentrates in the cells. And form and reacts with charged intracellular targets. With charged interacts with charged intracellular targets. That resulting in, just say resulting, you can check the book, resulting in DNA inhibition, interferes with protein, synthesis, aggregates ribosomes. Okay, so you can just go and have a look at the book at the proposed mode of action of this drug. The drug is pentamidine, which you have seen before. If you've done HIV, I'm giving you the other indication. It's a highly toxic drug. Side effects, you see severe hypertension, should be administered slowly over 2 hours because of these adverse effects. A patient should be monitored. There's pancreatic toxicity. Hypoglycemia can occur. Why? There is inappropriate insulin release about a week after the drug is infused that can persist for several weeks, followed by hyperglycemia. So there's hypoglycemia. Why? Insulin is released. It persists, and then after this, hyperglycemia can cause some renal effects and other general effects listed there, crashes, cardiovascular effects, etc. Then we have the next drug, suramine. And we have already said something very specific about suramine. Again, it's for early stage disease, and this one is more for the East African trypanosomiasis. East African one is tryposomal brucei rhodiensis. So it is the first line therapy for early hemolymphatic East African trypanosomiasis. Does not go into the blood-brain barrier. It is less effective if you use it for the West African trypanosomiasis. Suramine. So when you see suramine, remember the East African form of the disease. Mode of action, they say it's unknown. Okay, it is unknown. How is it given? It's given IV. It has got complex PK. It has very tight protein binding. It has a short half-life, but a terminal elimination of 50 days. So it's slowly cleared. It is a slowly cleared drug. Remember, for the East African type, administered after 200 milligram test dose. This is the second drug we're saying we test dose. The first drug we test dosed was amphotericin B. The regimen that has been used, an example here, it's 1 gram on day 1, 3, 7, 14, 21, or 1 gram each for 5 weeks. So there are some different regimens. It can be combined with pentamidine. Why? To improve efficacy. It can be combined with pentamidine to improve efficacy. Then it can also be used for chemoprophylaxis against African trypanosomiasis. Adverse effects, we have those general ones like fatigue, GIT effects. It can also cause shock and death. That is why we are test dosing the drug. Okay, and we have these later reactions that include CNS effects such as headache, GIT effects like diarrhea, hemolytic anemia, and agranulocytosis. So you can see it's quite a toxic drug. We need to test dose it. This is the structure of suramine. This is structure of suramine. The structure of suramine. Okay. And see it's a big molecule. Now, let me see, what else have I not told you about suramine? So go and check. But it can also be indicated for onchocercosis. I don't know if we've covered it yet. Onchocercosis. To clear the adult filaria. Yes, we have covered onchocercosis in this unit under helminths. So just note that suramine can also be used to clear filarial worms in onchocercosis. Yes? But the drug of choice is, you will check, what is the drug of choice in onchocercosis? Anyone? Can anyone tell me the drug of choice of onchocercosis? Have we ever done onchocercosis before?
Yes.
Oh, so where did we cover it?
When we were talking about in ocular dermatology.
Ocular dermatology, that is correct. And where else? Where else have we covered ocular dermatology? I'm not ocular dermatology, onchocercosis.
When you were talking about the nematodes.
Yes, when we are talking about helminths, yeah, correct. And that one we did actually in person. So there's no difference whether I come to class or I don't come to class. Half of you cannot remember ever seeing me that environment. So what was the drug of choice for onchocercosis?
Ivermectin.
Ivermectin, that is correct. It's the drug of choice. But you see why it is preferred. And the reason you can see it is preferred, of course, ivermectin is safer. You've seen this drug, you have to just dose it, and it has quite some many severe effects that you've seen, including shock and death, yeah, seizures, etc. So we have ivermectin. So let's just note it here somewhere as a note, and we can clear adult filarial worms. Filaria in onchocercosis. Leishmaniasis. That's just a note, yeah, as another indication. It's an IV treatment, okay? Because yeah. Now we now have the other drug that we can use for trypanosome infection, and we talked about eflornithine, which we were reminded we have seen this drug previously in what? We've seen this drug previously in dermatology. In dermatology, we've just been told for hirsutism, we can use eflornithine. It's a difluoromethyl ornithine, and it is an inhibitor of ornithine decarboxylase. Yeah. Now, this ornithine decarboxylase is actually a key enzyme in polyamine metabolism. Okay? Inhibitor of ornithine decarboxylase. Huh? And just know that a key enzyme in polyamine metabolism. In the parasite, polyamine metabolism. Just remember that. Now, when do we use it? This is the only new drug registered to treat in the, this African trypanosomiasis in the last half century. You'll check, maybe there's a new one, I don't know. It is now the first line drug for advanced West African or the Gabiensis type of trypanosomiasis. It is not effective for the East African disease. Eflornithine is less toxic than milazopril, but not widely available. The drug has limited availability until recently, when it was developed as a topical depilatory cream. Yeah, it removes hair. Hirsutism, depilatory. That's what it means, leading to donation of the drug for trypanosomiasis. That is what we're calling it is an orphan drug. Yeah, it's an orphan drug. It is administered IV. Good CNS CNS levels are achieved. And remember, when of course it's used as a depilatory cream, it is a topical ointment. It's a topical administered drug. Half-life 3 hours, about 100 milligrams given IV for 6 hours for about 2 weeks. And of course, the longer it is given, it is superior. It has more effectiveness. It is as effective as milazopril against advanced T. brucei-gabiensis infection. Yeah? But its efficacy against T. rhodiensis is limited. Why? Because of resistance. Because of resistance. Okay. Then, what else do we know about this drug? If you combine it with another drug called nifutimox, if you combine it with a drug called nifutimox, it can give better efficacy against the West African trypanosomiasis or the T. gabiensis disease compared to if you use it alone. So you can combine it with nifutimox. You can combine it with nifutimox. Toxicity from eflornithine is significant, but less than milazopril. Adverse effects are GIT, some blood effects, CNS effects. They are reversible. Increased experience with eflornithine and increased availability of the compound in endemic areas can lead to replacement of suramine, pentamidine, and milazopril. The treatment of T. brucei-gabiensis, which is the West African type. Okay? West African type. That is the molecule of, or the structure of eflornithine. The structure of eflornithine. Yes, eflornithine hydrochloride or chlorohydrate. So it is a hydrochloride salt You can see there the Western type of eflornithine. Here it is as a cream. Yeah, for a we think it is for hirsutism. Yeah, to remove excess hair. And when it is used for hirsutism, yeah, it slows growth of hair, yeah, by blocking enzymes thought to cause the hair growth. Yeah, so it is used as an anti-androgen. It blocks a DHT. Yeah, it blocks androgens. Now we've been mentioning milasoprol for quite a while. Milasoprol. We've just said we can use milasoprol together with eflornithine. What is this milasoprol? You said the milasoprol is for late stage disease. Yeah, and we've also said that eflornithine is also for early and late stage disease, but to improve the efficacy, reduce the even amount of time used for treatment for CNS disease. If you combine eflornithine with the 10-day course of nifurtimox, this is another drug, the efficacy against West African trypanosomiasis is similar to a 14-day regimen of eflornithine alone. Okay. Now, a place where we said you can't combine it again with milasoprol here. Why? Because you can shorten the treatment of eflornithine. When you're treating CNS effects, so the only time you use milasoprol is when you have late stage disease. In late stage disease, we have got CNS symptoms. Okay, so about this milasoprol, it's a trivalent arsenic compound. It's a very old drug, available since the 1940s. First-line therapy for advanced CNS disease, rapidly excreted after intravenous administration. It is administered in propylene glycol by slow IV administration. It can be repeated weekly if needed. Yeah. It's an extremely toxic drug. We'll see how it is administered. If we have time, we can look at a video. And the use of such a toxic drug is justified only by the severity of advanced trypanosomiasis and the lack of available alternatives. Immediate adverse effects are GIT effects and arthralgias. The most important toxicity is what we call encephalopathy, which can be fatal. This fatal or reactive encephalopathy. It can occur in about 2 to 10% of patients, about 5% of patients. And it causes cerebral edema, seizures, death. Other serious toxicity are cardiac side effects. And there's some failure rates, suggesting that there is resistance. So you might have to use both drugs depending. So this is what we're calling milasoprol. As you can see, it's an arsenic compound. It has acid compound. Okay. I hope you look at the structures later on. So you can imagine it's only given, of course, by hospital admission. But even the doctor has to be specifically dressed. As you can see, it's like a nuclear situation. It is in glass administration devices because it has the arsenic in it. Yeah. Given as if it is in a nuclear sort of environment. We look at a video too if we have time. I think that's all they have on milasoprol. But let me tell you again, it crosses the blood-brain barrier. That is why it is used in late-stage trypanosomiasis. Okay, it causes as a side effect this reactive fatal encephalopathy in a percent of patients. That is why it is a drug of, we can say it's a drug of last resort. There's nothing else you can give the patient is when you will give melarsoprol. It's when you give melarsoprol. Okay? So it has lethal effect on cells. The mode of action, it has lethal effect on cells. And let me just mention, maybe this slide does not have that information. I didn't read it. Does it have the mode of action? So you will just write, I think information is missing, that it's a prodrug. So it's a prodrug. It is metabolized to, just say, metabolized to melasine. 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 Metabolized to, we'll confirm the spelling of this too. Melasine oxide. And this is an arsenic oxide. Yeah, so this arsenic oxide, let's say that the arsenic oxide, reacts reversibly with sulfur hydryl groups. Sulfur hydryl groups to inactivate proteins in the parasite. So this is like I'm saying, most of this mode of action are suggested. So it forms what we call it forms this melasine, forms melasine oxide adduct. Yeah, from this melasine arsine adduct that competitively inhibits an enzyme in the parasite. Okay, melasine oxide adduct that competitively inhibits the trypanothione reductase in the parasite. This is how it's thought to have a lethal effect on the parasite. Okay, so here it is, as you're saying, it's arsenic, it has arsenic, hence the glass implements. In fact, see, the doctor is heavily dressed, will be heavily dressed. You can look at videos and see. Now we have this other American trypanosomiasis with Chagas disease. We said here the pest is actually this triatomid bugs. These triatomid bugs are what we said before, and also we can call them the Ludwig bugs. We can call them the Ludwig bugs. And they are also these triatomid bugs that carry the infection in the stool. So when they insect the Ludwig bug, I don't know if I've spelled it correctly, Ludwig bug. Yeah, this Ludwig bug, it's this kind of intermediate host that carries this parasite, the trypanosome parasite in the stool. And also it's transmitted again by placental transmission. I forgot to mention also the trypanosomes can be transmitted, especially the African types, as a case, through sexual transmission. It can be an STI. Okay, it can be transmitted as an STI. So here we can use two drugs. We've already mentioned nifutimox can be combined with eflornithine. So nifutimox is actually a nitroheterocyclic drug. And then we can also use benzimidazole, which is also a nitroheterocyclic drug for this American or Chagas disease. So these agents, both of them actually suppress parasitemia, but it can have a cure rate of about 60 to 80% of cases. Current recommendation that patients with either acute or chronic disease should be treated. And actually, if you look at videos, this Chagas disease appears to be a big problem in some parts of America. So for patients with late chronic disease, the cure is less likely. So both drugs are toxic and must be taken for long periods of time. They are nitroheterocyclic drugs. So this benzimidazole, yeah, American type of trypanosome. Now the nifutimox, yeah, a nitrofuran. It's a drug used to treat Chagas disease. Okay? It was being studied to treat African trypanosomiasis combined with eflornithine. Remember we said when combined with eflornithine, it reduces the days of treatment. And when we're using eflornithine, we said we're talking about CNS infections. Eflornithine. Okay? So that is nifutimox. Nervous structure, there is nifutimox. Okay? Yeah. So it is given, that is how it is given with meals, adverse effects, GIT effects, some CNS effects. These effects are generally reversible once you stop treatment. Footnotes. So that is the end of the class, I think. Let me see. I can put something else quickly. Do you have any questions as we are waiting to see if I can connect something? So, I don't know if you are able to see my there's a paper there. So there, you can look at this one and send it. I'll email you can have a look. So it just shows that this African trypanosomiasis is rare, but well documented cause of fever in the US travelers. So these people, they picked this disease in Africa. So they reported two, this is an old paper, I think. Let me see this paper. Check the year just now. But we reported two recently diagnosed cases that involved tourists who went on safari to Tanzania. So if it is Tanzania, it is trypanosomiasis brucei rhodiensis, not gabiensis. Already, I'm just saying it. Review of this and 29 other published cases indicate the disease in returning US travelers is nearly always of the East African form. Are we together? I just want you to get in your head. Remember, this person came to Tanzania. Tanzania is in East Africa. The form there is Trypanosoma brucei. That is a species. But which subspecies? We have rhodiensis and we have gabiensis. So it is gabiensis. No, it is not gabiensis. Gabiensis, we said, is in Gambia, West Africa. So this one is rhodiensis. Are we together? Is it rhodiensis or gabiensis?
Rhodiensis.
Yeah. So in the US, timely and appropriate therapy for this disease has resulted in favorable outcomes for most patients. Chemoprophylaxis for East African trypanosomiasis is not recommended. So although we had said one of the drugs can be used for pentamidine, can be used for prophylaxis, it is not recommended. Yeah. Travelers visiting areas of endemicity should use other preventive measures. You know how cover your skin, to prevent the blood meal in the first place. So here we are saying the take-home message number one, we have seen Tanzania, East Africa, rhodiensis type. Okay, you will read this. I'll email you, or you can check the writer. These are the writers. So they have the first case study. A 54-year-old woman. She had 2 days of fever, sweat, chills, myalgia after returning from Tanzania to the US on a 10-day safari. She recalled a painful fly bite on her hand while sitting poolside at a resort 6 days prior to becoming ill. Her only medication at the time was doxycycline. Oh, incidentally, I forgot to mention that aminoglycosides. Remember, we had mentioned paromomycin, and gentamicin. Those are unlicensed uses for trypanosomiasis and also leishmaniasis, because I mentioned them earlier in one of the slides. So just remember, we can use that as an unlicensed use. So this patient, she took doxycycline for prophylaxis of malaria. Now you'll see later on, next year, when we're covering malaria, you go and cover it yourself. The doxycycline can be given as a prophylaxis, given 100 milligrams daily for malaria. So this person took doxycycline. So after a stain, thick and thin blood smears were examined to rule out malaria. They saw triple mastigotes. She was admitted to hospital. She was febrile. She was not in acute distress. Physical exam were remarkable. Only soft systolic ejection murmur, no rashes, tryposomal chancres or organomegaly, and neurological examination revealed abnormalities. White blood cell count was that. You read the paper. Those were her white blood cell counts. CSF was also examined. Glucose protein levels were examined. No parasites were seen. So she's been checked. So blood smears, again, prepared for detection of trypanosomes were negative. Okay, so she got an intravenous dose of suramine, 100 milligrams. She received 1 gram at day 0, day 1, day 7, day 14, day 21. Within 48 hours of the first 1 gram dose, her fever decreased, her appetite and energy improved. Okay, so they looked at her blood, they saw the trypanosomes. She was given this test dose of suramine. And then after the test dose, I explained why she gets a test dose, it's a toxic drug. She then received the suramine on specific days. And within 2 days, when the blood smears were checked, there were no trypanosomes. Yeah, so the trypanosomes were negative. After the 3rd dose, she then got some other symptoms, leukopenia, thrombocytopenia, elevated D-dimer, decreased fibrinogen, slightly elevated trypanosomes, liver, slightly elevated liver function tests were noted. She left the hospital on the 5th day and completed therapy as an outpatient without incident. 3 months later, she remained asymptomatic, had normal complete blood cell count, liver function tests, and CSF. You see, they follow up the patient. Then there was this other man. There were case 2. Again, this patient was there in Tanzania. Again, we said Tanzania, East African type. It is rhodiensis. So he then comes, you read this, you look at this, story, and we can see that he had his blood taken, and from his blood, shortly after his return, he experienced profound malaise, daytime drowsiness, nighttime insomnia. He developed fever, chills, headache, myalgia, etc. A blood smear was done, and triple mastigotes were noted. Okay? Remember, we said triple mastigotes are from the bite of the tsetse fly during our blood meal. And they are metacyclic triple mastigotes that go into the skin. So this patient was febrile, he had all these other symptoms you will read. And then, let's go to the next page, what happened. These are his labs, exactly what happened. The labs were done. And then, even his CSF was done. There were no parasites in CSF. What did he receive? He received the drug known as suramine. Okay, received suramine. And from the suramine, remember, we had said at the beginning of the class that suramine can be used in early disease. So none of these patients have got late stage involvement. Suramine, you said, was for East African variety of the disease. East African variety of trypanosomes, suramine. Hope we're together. So he received suramine at the same dose in the first case. So he did a test dose, then on specific days, he then received the drug. During the first 3 hospital days, symptoms diminished, but he became jaundiced, developed diffuse macular rash, further depression of white blood cell, platelet counts were noted. The findings resolved after 2 days. Thin and thick smears remained negative after the 3rd hospital day. After the 3rd day of hospital, stay. He left the hospital on the 5th day, completed therapy as an outpatient. He remained extremely fatigued. Remember, we had a slide on how the patient will present. Yeah, and you can see they have drowsiness, hence sleeping sickness. So after some days, 3rd day, his blood is clear. He was fatigued. Even 4 to 5 weeks later, He reported no other symptoms. He was still well 10 months later, but refused to undergo another lumbar puncture to check if the disease had cleared. So those are two cases covered in this paper. But this paper also covers these other patients. We look at them. Here's the gemstone. Here is the trypanosome brucei. It is a flagellate. You can see the flagella. It is a flagellate. Okay. Again, here we're saying chemoprophylaxis is not advisable. Okay. So you can look at this paper out of interest. Not a very recent paper. And it's almost time. Let us check if there's a video where we can see melarsoprol administration. Melarsoprol administration. Video. I don't know if you'll be able to see my. Let's share something else. And something else. No. Let me try again. Let me see if I can put this video. If not, so as we're waiting, where are my 32 papers that I'm hoping to collect when I come? I'll come there, I think, on Thursday and collect my 32 papers. If you put more, it doesn't matter. I'll mark the first 32 papers. So this is can you see my screen?
Yes.
Okay. So I just want to see if we have a video of how melarsoprol is administered. Medication administration in the mouth, intravenous administration. No, this one is not good. I want you to see it is actually given as if the patient, the doctors are in a nuclear situation. So I think this search is not good. I need to go to Google. Go to Google. Search vector. Melarsoprol. To see administration. Administration. Let us see if it will give us the video. Slow IV. Remember, I've told you this organism can be sexually transmitted. So, patient should also be advised. If we don't find it, arsenic drugs, administration of arsenic drugs. Let's see, this is a medical site. No, it's asking me questions. If we don't find it, there's some movies you can go to and actually watch what happened. Like this one that used to be called House, and actually that specific patient was got the disease through sexual transmission, and then that I don't know if you know. Do you know that episode called House? That series? Ama you're too young. So go and
Yes.
watch how that is. Yeah, go and watch. There's one where I watched it many years ago, but I never forgot how the drug is given and what it does. So, like this is just the site as an injectable. I thought we'd see the video. It's not. How it's given. It's usually given in glass. These glass containers. It's a very toxic drug. Yeah, it's highly toxic. So it must be the patient must be treated in a hospital setting. I think today my searches are not good. Are you able to see my screen? Yes or no? Because now
Yes.
images, news, to the latest. Okay, it's not showing my videos. I have found the videos. Maybe the next time we meet after Christmas. Yeah, I'm going for Christmas. But let's look. This one is the Lancet. This Lancet. And you can see there's new WHO guidelines. I hope you can see. For treating the rhodiensis, that is the East African human type of trypanosomiasis. And the expanded indications for fexinidazole and pentamidine. So let us look at the conclusion here. The summary, it just showed some neglected tropical disease. WHO has revised its rhodiensis human disease treatment guideline for independent systemic literature review following the GRID method. I don't know, there is a lot of noise. So here it says fexinidazole replaces suramine and melarsoprol as a first-line therapy in individuals 6 years and older, body weight of 20 kilograms or more. Fexinidazole is more effective in both stages of rhodiensis, trypanosomiasis. A lumbar puncture for staging is no longer required. In setting in which first choice drugs are not available, immediate interim treatment with pentamidine is suggested. Introduction of oral fexinidazole represents an advancement in management of this disease. It's a life-threatening disease, etc. So, for your assignment, the one you'll give me after I come from Christmas, the one of 32, I'm collecting this week. It should be in the office. Someone called Stanley was to put for me in the office. You'll go and check this drug, fexinidazole. Fexinidazole. What is fexinidazole? What is the mode of action? Okay, because you see they're recommending it. But you see, we're in Africa, so if it is not there, you just go ahead with whatever is there. Yeah. In settings which first aid drugs are not available, you just treat with whichever is there. Remember that the disease is life-threatening. This is Lancet. Look, February 2025. Go and check which other new drugs are there. There's always new drugs. Whatever is in the textbook is not the end of science. There's always a new drug to treat. There's always new development. So look at this drug and then you tell me next year. Are we together?
Yes.
Okay. So put my papers, the 32 papers there in the office. I'm coming to collect them as soon as possible. Okay, so this, I really wanted you to see administration. Okay, it's actually given as if it's a nuclear drug. Yeah. We'll have found it by next year when we return for Christmas. So here, is this the right drug? Really? So can you see this video? Are you able to see my screen?
You can see the screen, but there's no video.
There's no video. Gosh. Now even there's a lot of noise. You know, I suggest you go and watch. There's this series called House, only because of the way the patient presented. Then she had had an affair, so she got it from a friend of her husband who had traveled. So it was sexually transmitted. And then how all other drugs were used, and the only thing that could save her was the milasoprol that had to be given with so much care, okay, under glass, and even like a nuclear kind of situation to protect the staff. But then, of course, it was already CNS involvement. She recovered. Okay, so will you watch? Just go and watch. At least it's not homework. It's a movie, like a series you're